Now, the third congenital disorder is the osteogenesis imperfecta, or you may hear it called brittle bone disease. Usually it's noted at birth, and that would be the autosomal dominant type, or it may show up later in life, which is the autosomal recessive. But it is basically a genetic connective tissue disorder. When it shows up later in life, that is usually, they're fairly mild cases that can be managed fairly easily. But it's a child that maybe is having repeated fractures that cannot be explained. The symptoms you see in a child with OI are kind of a blue-looking sclera, fractures that occur without trauma, early hearing loss, and in the more severe cases, you will notice back deformities where the back spine begins to curve and limb bowing in those children. A person may have only a few or hundreds of fractures over their lifetime. So I guess the severity of it varies a lot. We diagnose this by doing a skin punch biopsy. And with OI, you can end up with some severe impairment secondary to those pathological fractures. That would be a type 2. Or you could have milder symptoms like in type 1. Accompanying problems you do see are cognitive impairments. That's when maybe a child has a skull fracture and it does bleed into the brain. Orthopedic deformities, obviously dental deformities because the teeth become almost sharp and almost like little fang-like behaviors. There are certain medications that we can give these children to help increase bone density. There's nothing that's going to cure it, but we can give them some medications that help with bone density. And then we also recommend low impact exercise for these children. It does help to strengthen the bones for them. Okay, as far as OI, what it actually looks like. On the top left, this is where you see a OI mother who's given birth to a normal, healthy child. And you see the baby is as big as she is, basically. Anytime you have a mom who has OI, they are going to deliver her by C-section. That is not going to be a chance they take on her because she really doesn't have the bone structure to go through labor. Next, you see a classic dentation for a child who actually has osteogenesis imperfecta. This is what I was describing earlier to you. See how they're kind of pointed, almost like fangs would be on your children? Very classic. Top right is just a little girl who has OI. If you can note her, she has the arms are somewhat deformed, the legs are not right, and they all kind of have that same faces to me. They look similar to me. Bottom left is a newborn with OI. And also it have an x-ray that goes along with that. And you can see some of the fractures that probably occurred in utero because if we know we're having an OI baby being born, we will deliver them by C-section. So many fractures can occur in utero. And then on the right-hand side, you can see the blue sclera that I talked about earlier. And then below that is a mom, an OI mom who has had a baby. Once again, would have been via C-section. But the baby does not seem to have OI at all. So a healthy baby and the mom who seems to be doing very well also. So these women can actually go ahead and reproduce and have babies as long as they're delivered by C-section. The next topic will be the orthopedic problems that we see in children in general as they get older, not congenital. And that would be fractures, muscular dystrophy. There are 3 types of that, but the one that we will see in children predominantly would be the first one, which is Duchenne's muscular dystrophy, and then which is our pseudo-hypertrophic one. There are 2 others that we can see sometimes, but by far and large, we see Duchenne's, and that's what we're going to actually talk about. Next, we have juvenile idiopathic arthritis. We may see scoliosis, can be postural versus structural in that, and I'll talk about that a little more. And then Legg-Calvé-Perthes disease. Beginning with fractures. Fractures will occur secondary to trauma. Something happens to the child, they fall, they get injured, there's an MVA, something happens, and there's been some trauma, and they do break a limb or extremity or ribs, whatever. But we do know that children heal so much faster than adults, so the length of casting and the length of time that they will be either in traction, in a cast, whatever, is much shorter than we see with adults. What happens is if there's damage to the epiphyseal plate, that can actually result in abnormal bone growth, either stopping that bone from growing or it may grow abnormally. Some of the risk factors for fractures are kind of what makes sense. One of them is just being a kid. They play, they run, they're risk taking, they're doing flips and somersaults and climbing trees and all those sorts of things. And so those are going to make, by common sense, says they're going to lead to some trauma with these kids. They're going to fall, that sort of thing. Obesity is another aspect that could increase our risk factors for fractures. And then, of course, poor nutrition. If you're not getting a good calcium intake, the bones would be somewhat weakened. As far as assessment findings in a child who has a fracture, you're going to have pain over the bone. You may see bulging or an actual deformity of a bony area. And there may be warm to touch or maybe even some redness over that area, as well as some edema. In order to confirm a fracture, unless it's a compound fracture and the bone is sticking out, which would be obvious, we're going to do an x-ray on the child to confirm that there really is a fracture. Although in many cases, we really don't have a whole lot of doubt about that. It's pretty obvious to us. In caring for a child with a fracture, some of the interventions would be first to stabilize the patient at the time of trauma and make sure we're doing neurovascular checks regularly to make sure there's no vascular or neurologic compromise secondary to the fracture. Then we want to ask the child about their pain level, how much does it hurt, maybe give them some analgesics as ordered, and then as nurses we will be the ones assisting in the treatment, gathering the supplies for the doctor if he wants to cast it, those sorts of things, and then assisting actually in the placement of the casting, or if they wish to put them in traction, helping with that as well. As far as casting, the first thing we do is prepare the child, tell them exactly what they're going to see, hear, and feel regarding having a cast put on. Then we kind of tell them about the different kinds of cast, that the fiberglass cast will be much lighter if that's what the doctor is going to use. Usually we'll ask the doctor which type he's using. Majority of physicians, when they're casting a child, will use fiberglass because if we use plaster, it's much, much heavier, and care of a plaster cast is much more in depth. It's a lot harder to take care of, and it dries so much slower. Okay, then we want to look at the skin around the fracture and the cast once it's placed on, making sure that there's no neuro compromise. We're going to elevate the extremity after it's cast to try to reduce the amount of edema. We tell the parents to put on ice for the first 24 hours to the site so they can put it up on a pillow and then put an ice pack on top of the cast itself. Make sure mom and dad know how to do those neurovascular checks. We demonstrate to them during how to do cap refill, feeling the fingers, having the child wiggle the fingers or toes if it's a broken leg. We go through all that and demonstrate it to the parents themselves. Then we provide them some pain meds. The doctor will order the prescription, but we are always the ones who will explain it to them, how to give it and how much to give. If it is a leg fracture, we go over crutch walking with the child if it is age appropriate. If the child is 3, 4, 5, and it will be age appropriate for crutches, then we will start and teach them how to crutch walk. Do not let them leave the ER unless they have demonstrated to you that they can get on a crutch and walk around with it. We never send them home and hand them crutches without them ever practicing it. That's setting that child up for a fall. And then education in general about what to look for if there's any itching, those sorts of things, how to not put things in the cast, all those sorts of factors, the things we